Welcome to Beneficial Conversations. We will explore the world of employee benefits and dive into the trends, challenges, and innovations shaping our industry. Join us as we sit down with industry leaders, HR professionals, policy experts, and thought leaders to discuss strategies for creating impactful benefit programs that support employees and drive organizational success. So, whether you're an employee, a consultant, or you're simply curious, Beneficial Conversations looks to provide valuable insights, actionable advice, and inspiring stories to help you navigate the future of work. Welcome to Beneficial Conversations. I am CJ Jordan, your host. I am joined by the woman, the myth, the legend, Rachel Strauss. Thank you so much for joining me this morning.
Of course. Happy to be here, CJ.
Yes,
It's a
well,
Friday when we're filming, so it's like a happy day.
it is. It is. We can get this done and kind of just inch closer into our weekend.
Yes, sir.
So I start things out a little different. This is not going to be anything insurance related, but it's the standard question that I ask to everyone that's going to be on this. I want you to tell me about the best meal you've ever had. It can be something that y'all cooked at home. It can be a restaurant that y'all went to. I want to hear about your best meal ever.
I mean, that's a pretty on the spot question. Um, Let me, oh boy, I want, because best could be defined in so many different ways. Best could be company, it could be laughter, it could be
It's open to
food
interpretation, so it doesn't always
itself.
have to
I
be the
mean,
food per
I'm
se.
just gonna go like in recent memory because I'm sure that I've had a million. But my 45th birthday was a couple months ago, and my husband was able to pull off a surprise party for me. And I would say that it was, really one of the best meals I've had in a long time because it was I felt loved, I felt celebrated. I felt seen, and it was just a really great way to share it. And my parents, my dad and stepmom, happened to be in town. I never thought we would ever go out to dinner because we're from Detroit, and the
Okay.
Lions won the last football game of the season. Unfortunately, they didn't know it would be the last, but it was a really good night.
Hey, that's it. Because Luke and I talked a little bit about it. It doesn't always have to be the food. It can be just the experience, the ambiance, the aesthetics that go with it that just kind of elevate the whole thing. So I'm
Yes,
glad we had a great experience. Birthday always makes it a little bit sweeter.
yes, 1000%.
All right. So tell me a little bit about your background. Obviously I'm a little familiar with it, but I want to hear a little bit about your background, how you got into this space, kind of what you're doing now. Take me through it.
Yeah, sure. So I got into this business by accident, obviously, because I don't even know if I knew what a PBM was, let alone that I wanted to work for one.
Uh-huh.
So I have been in pharmacy benefits for 23 years. First job out of college. And it was really, it started out as knowing somebody who owned a pharmacy benefit manager that wanted me to, come help her while I was figuring out what I wanted to do when I grew up. I was freelance reporting at the time. A lot of people don't know I actually have a background in journalism.
I did
I was a
not.
reporter. I freelanced for Gannett newspapers. I worked at a daily newspaper. As much talking as I do, I was able to be the interviewer, not just the interviewee. And by accident fell into this industry. And really it was because I was so fresh out of college, CJ, that I had a lot of understanding in Excel, and I ended up temping for somebody in underwriting, just putting in numbers into a pre-done um, spreadsheet. And
Yep.
so they had me in underwriting, and it wasn't long before a broker called and asked me about something that I had done, and I was like, well, I don't know, let's figure it out together. And I went behind the scenes, and then a week into my stint, he asked me to go to a meeting. I'd never been to a meeting before. This sounded very exciting in my 22-year-old brain. And so I went to the meeting, and there's a little more to that story. The CEO, kind of was like, "What do you mean you're going to a meeting? You've worked here a week." I'm like, "Well, somebody wants me to go. I'm going to go." And I ended up, kind of learning a little bit, and then she finally said, "If you're going to do this, you're going to do it. We're going to put you full time, and you're going to learn it." And I never looked back. So I started in the healthcare industry, in underwriting for pharmacy benefits, understanding, what went into, how it worked, from understanding how many medications people take to what the spend impact was. I was around I sound like I'm 100, but I was around when drugs started getting very expensive. I remember it started with MS and HIV drugs. Those were the big scary ones by cost. 15, 17 years ago. And then it just, continues to go up. I mean, there were specialty drugs before specialty was coined. And so
Yeah.
really understanding, how the impact is. And, a lot of people don't think about it, but pharmacy is actually the number one most utilized benefit that is sold in an employee benefit package. So if you think about it, you can sell medical, dental, vision, all the other things,
Yep.
but it's the prescription somebody gets every month that is the most used and, most impacted with the member, from a overall percentage standpoint.
So, well, and you touched on that. So when you talk about percentage and stuff like that, when we talk about claims and everything like that for a company, on average, what are you seeing the prescriptions make up when it comes to claims? What percentage of claims come from the RX side?
So I don't know by actual number of individual claims.
Sure.
If you consider, I don't know the medical stats quite as offhand as I do pharmacy, but the average person, so that includes dependents,
Hmm.
uses just under one script per member per month. So you're talking about a family of four is going to use about 3.5 scripts per month. So, you're talking about 40 claims a family a year. I don't know how that compares medically. Financially, I do know pharmacy on average is about 20% of the overall spend. So medical certainly is higher, but you are now starting to see where pharmacy can be upwards of 30, 40%. And that's like where I think pharmacy is starting to get a lot more attention than maybe it used to 5, 6, 7 years ago. And that again is a testament to how expensive medications continue to get.
Yeah. And I think I've heard somewhere in that 20 to 40% range, kind of what you were talking about. So I'm glad that, that's kind of consistent.
Yes.
And so we've thrown around the phrases, and you and I, we talk about this day in, day out, but just laying the foundation for people that may not be quite as familiar with it. What is a PBM and what is its function? We'll start at the absolute bare bone basics, and then
Yeah.
we'll start to, build up from
Yeah,
there.
no. So a pharmacy benefit manager was, originally created as the system to be able to process medications through a health plan. So if you think about it, CJ, like when you use a credit card, right? You have to swipe your credit card so that the merchant, the store, knows number one, who to bill because there's a background, entity that is paying for whatever you're buying. There's money behind that plastic you're swiping, a concept my husband still tries to explain to me, but he would find it comical that I'm explaining how this all works. But so when you're swiping that credit card, you are having essentially an electronic communication from store where you're buying to bank. And then that bank is also giving money to another bank because that's how the store gets paid to their account. It's a very similar transaction that happens on the pharmacy side. So a person goes to the pharmacy, they're presenting a medical card, right, which will have on the bottom pharmacy information. A lot of people don't realize that because you have a Blue Cross card in your wallet, it may not be Blue Cross that is, most likely it's not Blue Cross paying for your prescription drugs directly. It is going through what's called a BIN number, a BIN, which is the identification number that I think it actually stands for banking. It may even be banking information number. I'd have to Google that. But the BIN number is what tells the pharmacy what PBM is in place. The PBM is then going to run to make sure that you are the correct patient, eligibility, kind of like the banking side. When you buy something from the
Yeah.
store, is there money available? Is there the claim allowed to go through? And then the PBM is the one kind of the middleman in between, paying for the cost of the medication, making sure the member gets it, and then billing whoever's responsible ultimately for the price of that prescription. And, so that's, really the function of why PBMs were created 35, 40 years ago. What they have evolved into is, this behemoth of an industry that I would probably argue 8 out of 10 Americans doesn't even know exists, maybe even 9 out of 10. And, PBMs are really who are the gatekeepers of not just, what pharmacies can, provide the medication, but unfortunately what drugs are also going through.
Mhm.
And that's where we begin to peel layers.
Yeah, I was talking with a couple of my buddies this morning and told them that I was recording a podcast. And they're like, "Oh, what's the topic?" I said, RX and PBM. They're like, "Oh, that's great." As I Google what a PBM is,
Right.
and I'm like, "All right, yeah, this will be a longer conversation later." But I
Right.
think you're right. I think, most people just assume like I show up at CVS, I show up at Walgreens and, here's my information and I get the prescription and that's it. But there's so many moving parts behind the scenes, so many different people that, are impacted by it, or there's so many just touch points that are just, I think, oblivious to maybe the normal person or the average American that's going to get their prescription.
Yes, 1000%.
So, um, you know, I feel like there's a lot of talk lately about the big three when it comes to PBMs,
Yeah.
and I can't remember what the percentage is as far as what percentage of the market that they hold when it comes to all
Majority.
that.
More
Yeah,
than
majority.
50.
Yeah. So what is the big difference between your big three and maybe some of the what you and I know to be transparent PBMs out there? Like what is the big difference between them?
Sure. The biggest difference is essentially how, the PBM is paid for the job they're performing and how they're, explaining it. So, the big three PBMs, and for those that are kind of getting up to speed on what this all means, the big three, which are again still not household names. Well, one of them certainly is, which
Sure.
is Caremark because it's owned by CVS.
Yeah.
CVS is certainly a household name. United Healthcare, another household name, owns a company called Optum. And third and finally is Express Scripts. Those would be the big three PBMs. And what has separated them from virtually every other PBM in the country is that they have not been as forefront with how they are earning their revenue.
Hmm.
And quite honestly, that's because they don't itemize it. They just process medications, employer groups, Medicare, everybody just, kind of pays the bill, but they're not explaining where their profit margins are. Whereas in the transparent space, it's a little less vague. I'm not going to say it's all perfect,
Sure.
but at the very least, there's administrative fees. There's a per employee per month or per contract per month or per script revenue that is being disclosed. And there's a little bit more access to, how you can figure out how your pharmacy benefit manager is incentivized to make money.
Yeah.
The big issue has been that these big three PBMs have clearly been taking advantage of medications, expensive drugs, profit margins that they can make from pharmaceutical companies. And again, without it being disclosed, there's a lot of opportunity for these companies to put profits over patients and to really try to push, some of these big brand drugs through the market.
Yeah. And so, I guess being in Alabama and, obviously Blue Cross Blue Shield dominated and, I know that they own Prime Therapeutics. Are they coming up as far as it almost being a big four? Are they just not quite there yet? Like, what are you seeing from your side? Are they just not quite as
Well,
big
Prime
or?
is Prime is no longer. Prime was excuse me, no. Prime is very much longer. My brain is exhausted this
I
morning.
was
They
like,
just
wait a second.
bought Magellan. So yes, I
Okay.
would say there because they just bought Magellan, my brain is all over the place. Magellan becoming part of Prime is going to, yes, definitely put them as one of the big four, if you
Hmm.
will. They're trying to be a little bit different than the other three PBMs by nature of they are showing some of their administrative fees
Hmm.
when they're on their own as a standalone. The issue again is when Blue Cross has everything, there's still a little bit of murkiness into how that's all being managed.
Yeah. And so on the transparent space, for maybe some of these groups that, are evaluating their options or, they have it running through the big three or the big four or whatever, where's the biggest opportunity for them to win, maybe both from an employer standpoint as well as an employee standpoint? Because, employees, I feel like they'll be interested in it if it also benefits them, but, they also need to understand, hey, like, it can't just be good for them. It's got to be good for me. So where are you seeing some of the success on the transparent side compared to maybe just the traditional big three, big four?
It's all in flexibility. That's kind of how you can, decide if your pharmacy benefit manager is doing the right thing, either for you as a member or for you as an employer group. I don't think at the member level, people really care unless they get a script that their doctor says that they should take and then it's not covered. Right. That's when
Hmm.
a member starts to, kind of, say, oh, my insurance sucks, but there might be a reason why it's not covered to begin with. And, I always say that it's really in the consultant's standpoint or the employer group, because the employer group is always going to want to do what's ethical for their employee, as well as, be strategic. And so, where there's all these strategy solution providers, I think that's where the voice and, where you can kind of come in and say to your partners, who do this job of providing pharmacy benefits, hey, I found this really unique idea. I'd like to put this in play. And the answer from the PBM will tell you everything that you need to know.
Right.
I will say sometimes it is, coming from the vendor side, it's not always easy to, do every solution that's out there, because
Sure.
there's integration, there's cost associated with that. I've had a job for 23 years from a pharmacy benefit manager, and they have to make money. Otherwise they can't do their job. And, we're in a world
Sure.
now where it seems like nobody wants anybody to make any money. But you've got to have something, because otherwise it doesn't work. And so you've got to be, as a consultant, you have to be understanding that a PBM may charge you to do certain things,
Right.
and they should be able to do that. But if they're a flat no, we're not going to do that, or no, we want to do everything ourselves, that's when you need to wonder, why is that? And if the PBM is insisting on doing things themselves, are they showing you that they're moving the needle?
Yeah.
Because if they can't show you they're moving the needle, and they're not willing to work with outside vendors, even at a cost, you don't have somebody that's a team player.
Yeah. Well, I think you brought up a good point. I mean, it's important, like companies have to make money to stay afloat, right?
Mhm.
But I think a lot of it comes down to, and I've heard you say this before and several others, but all of the money. Like, how are they making the
Right.
money? Is it just, rubber
I would
stamping
rather see a PBM with a higher transaction fee, a higher per claim fee, but that's because they're doing the work to integrate with 4 or 5 solution providers. They're doing J-code management, they're doing international, they're working with manufacturer programs, and it's all above board, and
Yeah.
they're kind of showing you how they're doing it. And if you're working with an outside company that's helping do the work, the PBM still has to interface with that company. It's not so simple. But if the PBM is not going to do that, then you've got to understand they're making money from another side of the business, which is rebates, formulary management, pushing drug A over drug B.
Yeah. Well, and rebates is a kind of a buzzword, and I think you and I have talked,
Sure.
at length about this. So let's go ahead and hop into the rebate world, because I feel like a lot of people, and even when I started in this space, a lot of it was, hey, we can get you, look at all these rebates that we can get, and it just seems to be this look over here thing. So give me your thoughts on rebates. Are they good? Are they bad? Walk
Yes.
me through kind of your side of it.
I have for decades believed rebates are probably one of the largest reason this industry is moving backwards. I do not think rebates are good. I do believe, unfortunately, I have had to shift my opinion. I, for years, said you could operate with none of them totally out of the picture completely. That was, in fact, where I started at EHIM, that was our original model. No rebates, you know, just manage claims, and we were able to do it for decades, I will tell you.
Sure.
But with these GPOs and, and again, to not speak in just 3-letter acronyms, with group purchasing and, offshore rebate collections, it has changed the game, because there are dollars and you can't exist without them altogether, but they should never be the first, resort.
Hmm.
Um, again, I always laugh in my personal life. I'm all about tax refunds and, trying to tell my husband something's tax deductible. If I want to go to a charity event or some gala or something, and I'll have to explain, we still spent money. Doesn't mean we didn't spend anything. It means we still spent money. And yes, it could be a charity write-off, but you still spent money. And
Yes.
it's the same concept with rebates, right? And so you've spent money. And the question is, did you need to spend that money? And, that's kind of where I'm back to this holistic approach about really understanding what is driving the rebate. If you can get the drug low net without a rebate, that should always be the first approach. And, if you have a PBM that is going to penalize you in any capacity because you did not get the rebatable drug, that's, again, where you can say follow the money, like you mentioned before, because that
Right.
that is inexcusable.
Right.
We live in a world now where there's all these government programs and 340B, federally qualified health centers that want patients in their network to offset seeing people for free. And if they can do something, you don't get a rebate when you go to those facilities. but they're able to offset costs immediately to the employer. I would argue, even if the rebate is equal, why would you not want the savings immediately than to get that money 18 months down the road?
Hmm.
And, there's still so many people who are taking hands in that piece of the rebate anyways. Even in this space, CJ, we talk about pass through rebates and all these things. Everything's pass through of what? I mean,
Yeah.
I guess I'll go back to it's accounting because I think it's what everybody understands. We all get tax refunds if we earn, if the way we don't all get refunds, but if regardless, you likely still paid somebody to get that, right? Whether you paid an online system or you paid an accountant, somebody is still doing the work before you
Yeah.
get what you get, unless you are yourself a CPA. But the end of the day is you are paying somebody to get a rebate. Even in 100% pass through world, there's an outside entity, there's a holding company. I laugh that the big three are coming out with these pass through programs. It's like, of what? Pass through of
Yeah.
what? Like, what your holding company gave you to give back to the employer. And again, we're changing games, and we're putting different loopholes and curtains up. And I think rebates, people need to understand, it's a mechanism of pharma to buy market share. That is simply what rebates are. They're not coupons. They should have just made the drugs less expensive to begin with, but that's not how they
Novel.
move the needle. They move the
Right.
needle because rebates are offered.
Yeah.
That's why drugs aren't cheaper to begin with here in the United States.
Yeah. And we can kind of get into the international sourcing part at some point, but I mean, it's just wild to see, again, we've had conversations and I've heard other brokers kind of talk about, well, we ended up going with this option because, the rebates that they were showing on the spreadsheet were exponentially higher. And it's like, I mean, but like you said, like rebates off of what? Like, I mean,
Right. And I mean, the entire bidding game is such a joke because PBMs are doing triple dipping. They're showing high rebates, high percentage yields, high savings programs, but like you're not going to get all three. And they show all three on these spreadsheets, and there's no adjustment for like if you like I've seen rebates given when they were also showing the drug was going to be gotten for free on a patient assistance program. You can't,
mhm.
it doesn't work like that.
So if you're an HR or a CFO that's kind of evaluating something, if you're looking at maybe moving self-funding and and you're starting to see this, what are questions that you're asking from an HR or a CFO standpoint when you're, evaluating some of these options, likely with a broker or something along those lines? What can they be doing to make
So
sure?
it's company specific, unfortunately,
Sure,
because
and
there's
there's yeah,
some
there's
companies that only care about the bottom line. You have some companies that care more about like noise and not wanting people angry and upset.
yep.
Everything gets to, how much skin does the PBM have in the game? You asked about, where my career is going and what I'm doing. Likely by the time this podcast airs, and if it hasn't, then you're getting breaking news before I announce it on LinkedIn. So if this airs before March 15th, you better tell me, CJ.
It
But
will not. You're good.
okay, good. All right. Well, I am launching PBM Princess LLC, if you
Let's
will.
go.
So a name, by the way, that I can tell you some of my family outside of my husband did not love. They're like, no woman is going to want to work with you if you call it PBM Princess. I'm like, they have ways. So this is just who I am. And so why I am doing PBM Princess is because I have learned that I have a voice in this industry, as do you with a podcast, right? I mean, I want to give voices to companies that I believe are doing the right thing. I want to manage pharmacy benefits. I don't want to work for the pharmacy benefit manager. I think they need a manager themselves. And so my goal is to be brought on by consultants, by employer plans to hold PBMs accountable.
Love
Create relationships with multiple PBMs that I do believe are doing a good job.
it. Hmm.
And in some cases, I have a client already that does guarantees. They are able to come in and like say, you will not spend more than this amount of money per month.
Love
That is what an HR manager wants to hear because that means that, in this world of fiduciary responsibility and being beholden to a self-funded plan, you want a PBM that's going to say, yeah, we're going to do that. Or the risk taker could be, a different company. And if somebody else is coming in and putting dollar risk, I think that is where this industry needs to move because we do it with stop loss, but we're not doing it right to the contract level.
it. Yeah.
And, I think it just makes it so much easier to have skin in the game and to really work to manage those high cost claims.
No, I love that. And I love, that you say you want to manage it because it is, in my opinion, like it is an active process. It's not something that you just sit back, congratulations, you're in this PBM now. And then, like from the broker side, like I don't want to just sit back and be like, okay, my work is done. I I enjoy working with PBMs who are evaluating things that they're coming in and they're seeing, and it's like, hey, I see that this prescription is coming in. I know that we've got an alternative, that we
And
can get.
that's kind of, I've been a lot around long enough that I know all these clients. I know all these, there's a million vendors out there that do different things. I also know there's like vendors who are working with vendors underneath them. So my goal was to go direct to these vendors that I know that there's like other GAs for, and not charge for them. And
Yeah.
I'm trying to change this percentage of savings model, and just really find the right partners. And if the PBM doesn't want to work with the solutions that I can bring to the table, that's all you need to know,
Yeah. Yeah.
because my partners don't charge for what they do.
Yeah. And
They build
so,
it in into the cost of what the service they're providing.
sure. Yeah. And again, like it's okay to make money as long as
Yeah.
there's transparency with it and
Yeah.
it's not just, hid behind this cloak and dagger approach to things. So, I mean, I completely am on board with that. So we've talked, what can the groups who aren't self-funded, who don't maybe have the ability to carve things out or do that? I mean, is it just kind of okay, we just kind of go with it? Like what are you seeing? What are people able to do now who, are fully insured and just kind of like stuck with where they are?
So I think that it's double-sided. Okay. So the first and foremost is you've got to get people comfortable with maybe Blue Cross and United and Cigna and Aetna are not the end all be all of health plans. And that's where you ask, what can a group that can't be self-funded do? That's the first part, is understanding, maybe they need to leave that environment in order to see change.
Yep.
And I my next week's newsletter, I just wrote about this, and it was inspired because I saw somebody at a charity event, and they, I was just talking to them, and they mentioned their Medicare card. And she goes, I use this company, I think it's called like WellSave. I don't even know. I'm not in the Medicare space, but she mentioned a vendor I'd never heard of. She goes, I tell my friends it's cheaper than any of the major carriers, and I think I have better coverage. I go, exactly. I said, it's like when we get something at Target, like, there was a time where bargain shopping was kind of like, you just didn't talk about it. Nowadays, if you're wearing something and someone's like, oh, I like that, you're like, it was $10. I got it on Amazon, or I got it at
Yep.
Costco. And it's like, why don't we have that same mentality with healthcare if it's good? Like, why can't people talk loudly and louder when they do find something that isn't the major bukas?
Yep.
And that is, I think, what an employer group has to be willing to say. This whole very unfortunate, and again, I hate to take a travesty and use it for a narrative, but unfortunately, with the murder of the CEO of United Healthcare, I think what it did is it caused a huge ripple, right? You've had all these people with an opinion, talking about how United Healthcare sucks. And my biggest issue, is somebody on this unique space that only serves, 15% of the market outside of the big three. The number one reason I lose groups is because I hear that an HR CFO didn't want to leave United Healthcare. They didn't want to leave Blue Cross, but yet the people are speaking. They don't like the way they pay claims.
Yep.
So that's how an employer group can make a change, is by being, you made me do this early on a Friday, Thursday night, mom's, my brain and my words are still like finding each other somewhere in the middle.
Yeah, you're good.
No, it's all good. But I think, you've got to be willing to say, like, this is what we're going to do, and then tell their friends about it, tell their other CEO networking groups about it, because that is how you make a change.
Yeah. Are you seeing, you know, with what, Good RX or Mark Cuban's Cost Plus? I mean, are you seeing success for them to kind of go that route, or is it not really?
So GoodRx is really just another mechanism of a PBM. That
Sure.
is, they are utilizing pricing from a few different PBMs. There is still a PBM adjudicating the claim.
Hmm.
If you use GoodRx and you aren't insured, you are not getting credit for your health plan because it is an outside vendor. So like what that's done is it's caused some transparency into the market and the cost of
Hmm.
medications. And I think that that's one good thing. Mark Cuban has a name that is much bigger than Rachel Strauss, no matter how big I can make my LinkedIn, will ever be. And so I think that when you've got people like him that are bringing attention to our market, that's great.
Yeah.
I will also say Mark Cuban is literally on a show called, The Sharks. He is an entrepreneur who has
Right.
figured out a way, yes, to solve a problem, but he's also making money.
Right.
So, I think that when you look at these programs and you look at the space, these are all solutions to educate, but there's still better ways to do them. Right. And so there's still smaller guys that are not Mark Cuban that
Right.
he just took a model and added on to it.
Yeah.
Mark
Yeah.
Cuban is not a PBM. Just everybody needs to understand they're a metric and a purchasing model, which he does have some medications that he was able to get and beat the entire market. And
Sure.
that's it should be one mechanism that is in place. To
Right.
me, every PBM should be working with Mark Cuban with
Yeah.
cost plus
Yeah.
when it
Again,
makes sense.
you don't have to strictly go this route. You don't strictly have to go this route. I mean, like what you said, I mean, you need to be working with a collection of, vendors or PBMs need to have groups that they need to be willing to work with in whatever
Right.
capacity to drive those claims and those costs down.
I just laugh because Mark Cuban took the old PBM concept, which is how it used to be years and years and years ago. Cost plus is literally the definition of what spread pricing is. It is
Yeah.
the cost of a drug plus some admin fee that he's going to make.
Right.
And it's funny because that is what the entire PBM industry got beat up for was spread pricing. I mean, in fact, it's illegal in most states. Like if you are a PBM with spread pricing, there's like
Hmm.
a lot, including my home state of Michigan. I mean, you cannot have spread pricing in Michigan on generic drugs. But he recreated it and was like, we're going to tell you what the spread is and we're going to undercut what discounts are and what MAC pricing is. And so like it's just funny because he's like doing what everybody was attacked for, but being transparent about it. So it's
Right.
like it's just a very strange place.
Yeah. I mean, I guess it's one of those like I'd rather you just tell me up front as
Yes,
opposed to. But I
yes.
mean, like, it's you know I think, and this is a weird parallel, and it just came to my mind, and it's probably not exact. But like, I would rather you just tell me, like, if you're gonna bake something into my cost, or like, just tell me what it is up front instead of like having this larger amount. Just go ahead and let me know up front what it is. Like, if it's hotels or anything like that, and you're seeing these things, like, just tell me what it is right there, and I can accept it as opposed to just these arbitrary things that are getting pulled in. I feel like almost was it Airbnb or VRBO that was getting crushed for it, where they had to come in and change up their pricing model or at least be more transparent with some of these pricing models that were coming out because people were getting so frustrated with these exorbitant costs.
Yep.
Again, it may not necessarily be an exact correlation, but that's just kind of where my mind went initially.
Yeah.
All right, so GLP-1s, that's the trendy topic. I've got a couple of questions on this, but what are you seeing from your side in that space? What's new? I feel like there's been, it seems like it's ever changing, and next week things might be a little bit different than they are this week. But
I
what are
mean,
you seeing from
you're
that
just
side?
seeing complete and overall dominance of a pharmaceutical company, what's happening right now. So GLP-1s, Ozempic and all the things, right? So it's interesting. So first, these medications came out years ago to treat
Hmm.
diabetes, right? And that was, they were always expensive, but they weren't as prevalent in a population. We just didn't see them being prescribed all over the place. Then, they get FDA approval for a couple medications that are renamed and rebranded for weight loss, right? So Ozempic helps with weight loss. Then we have actual specific things for weight loss. Then we have short supply of all the medication because everybody's trying to get it. And
Right.
then you have not biosimilars. You have compound versions of these medications that are
Mhm.
allowed to be sold even with copyright laws because of the short supply. Now, because of this episode running, what's interesting is there's no longer a short supply. So now Eli Lilly is going after all the compound medications and they're trying to get them off the market because like the semaglutides and all these things
Mhm.
because they want market exclusivity. And then
Right.
during the Oscars, they ran commercials saying that, maybe Ozempic was never designed for weight loss. And it's like they're starting to roll back the number of people that are taking it for weight loss, which I'm also, again, I try to not be too much of a conspiracy theorist, but there's something going on there when they're saying that during the Oscars, where you've got an entire room of people now to size 00 because of Ozempic that they've been
Right.
taking in Hollywood.
Right.
And so, I think that at the end of the day, how this affects the benefit space is that employers need to know how they stand. They need to know if they want to pay for it for weight loss. And if they don't, they
Hmm.
need to know what they are paying for those that are on the medications, right? And
Yeah.
that it is, for the right disease state, and making sure that all of the other control factors are in place. Is there wellness preventative? I mean, if you've got a lot of diabetics, there's a lot of lifestyle that needs to go along with that.
Yes.
And just making sure that the return on the investment of paying these medications is coming back to the employee's own health and wealth.
Yeah, and I feel like I've gone back and forth on, just GLP-1s and, where I stand on them and things like that. But so, and I'm going to pull this up so that I can get it correct. So I wear a Whoop and I'm a big fan. I love it. I think
I
it's
am
fast.
too, until it starts eating my skin. I'm on a break. I love my Whoop, but right now I'm like, I just can't, because I get the skin reactions from the band. But I do love the Whoop. I just don't have it.
So Will Ahmed, the CEO, came out and they had been doing a study on GLP-1 users on Whoop. It was over a 12-week period, and what the broader physiological impact looked like on your resting heart rate, your heart rate variability, and your sleep architecture. And so I'm going to take you through this a little bit because I promise I'll land this plane. But they said Whoop members on GLP-1s lost an average of 10% of their total body weight in just 12 weeks,
Yep.
which is nearly twice the typical amount of people who took GLP-1s without the Whoop. And then it said the resting heart rate decreased by 3.7 beats per minute. HRV increased by 9%, signaling improved cardiovascular function.
Which you'd expect.
Um, yes. And then GLP-1 users boosted physical activity by 30 minutes per week over 12 weeks. And so it suggested that exercise may counteract some of the GLP-1's cardiovascular side effects. So, part of my question is, we understand that some of the biggest drivers of claims on, a company's health plans can be, high blood pressure or high cholesterol and things like that. And I feel like people take obviously the GLP-1s to reduce maybe their body weight and counteract some of those issues. So not saying that GLP-1s should be the first step for people, but do you see an overall net positive on GLP-1 usage as it relates to potentially reducing some of these chronic diseases on other
Too early
plans?
to say.
Too
And
early to
again,
say.
you're talking about off-label use GLP-1s. If somebody's diabetic and needs GLP-1s, like, yes, without question.
Sure.
And it's not off-label use. I shouldn't say that. It's FDA approved. I think that it's
I get you.
whether or not it's because, listen, we're also seeing spikes in other type of issues that are coming from these medications,
Mhm.
gallbladder issues and pancreas issues, and what happens when they go off of these medications.
Right.
I mean, this is now, so time will tell what it will look like. I think
Mhm.
that when you have Whoop user data, it's also like skewed, because people who typically own Whoops or any type of body tracking devices, which, by the way, I saw a funny meme that said, that these activity fitters are the new Tamagotchis. That you are a little younger, but it said, but the dumb
No,
animal
I
you're trying
remember
to keep alive
Tamagotchi.
is yourself. And that's what I always think is so funny. Like, we're the Tamagotchis.
So,
But when you're wearing one of those, it's because you're actually taking an interest in your life. Most people
sure.
don't buy a Fitbit to watch themselves have 74 steps a day. I mean, they're
Sure.
buying it because they may not hit the 10,000, but they're aware of their step count.
Right.
So I think you do have skewed data when it comes from a Whoop or something like that, because you're
Right.
working with a population that cares.
Yeah.
Um, and so I don't know. I think time will tell. I hope so. I'm optimistic. But we'll see.
Because my wife is a big, she listens to the Toast podcast. I don't know if you,
Yeah, I'm very familiar. I'm a toaster.
Yes,
Yeah.
yes. My wife is huge into it. And so, she had told me that one of the hosts and her husband were both taking,
Yep.
uh, but it gave them, through their use of it and stuff like that, it gave them the confidence to be able to maybe start going to the gym and
Oh
stuff
yeah,
like
no, I
that.
mean Claudia ran a marathon or a half.
Right.
It might have been a 5K. I don't know. I don't want to get too crazy there, but yeah, no,
Did
I mean
something.
yeah, and then she got pregnant. So it's like it'll, time will tell. She had to go off of it because of having a baby.
Oh, wait, did I lose you?
It says, no, I don't. Are we here?
Oh,
Did I lose you?
no, there you are. Okay,
Okay.
there.
I was saying that
So
the host that you're talking to about, she got pregnant, so she went off of it. And so now, she'll go back on it I mean, she talks about it every day, like how she can't wait to go back on it. But, she gained all the weight and then some back, I think she said.
yeah, I thought it was just it was something that I'd never considered, I guess. Like, obviously, there's the price tag that gets associated with it that we all understand,
No, I
and
think
that,
most people do get healthier.
yeah, it was just like I hadn't really thought of it in that respect. Where is it, again, not a step therapy necessarily, but it maybe gives people a little bit more confidence to take that step, and could it theoretically, counter some of those high cost things? Again, I think you're right when we say too early to tell, but it was just kind of a new angle that I hadn't considered before, just trying to be open minded about these things and everything. But it was just, that was kind of a fascinating thought to me.
Yes.
So give me your 3 to 5 year projections on the, what do you see? And I know this is tough because, I mean, like we said earlier, it just changes so frequently and so fast. But what do you think is going to happen in the PBM space in the next 3 to 5 years?
So Washington is involved. I think this is a bipartisan issue, and I think that like him, hate him, whatever. I think had Elon Musk not come in so blazing with everything he was doing with Doge, I think we would have had some reform get through pretty fast within this new administration. It's from the previous administration because, I believe that there is enough noise now, in PBM. I'm actually flying tomorrow to Nashville today. Today's Friday. I'm flying at 6 o'clock tonight to Nashville for tomorrow to film a documentary about the
Okay.
PBM industry, which I'm very excited about.
Love it.
And I just hope that what it does is it doesn't become just like Washington boring, C-SPAN stuff that goes to like die. I hope it becomes something that your average American listens to, because I do think that all this reform that's coming is going to, make a lot of eyes open, and business practices change.
Yeah. And I think a lot of it comes down to, people like you who are willing to speak out, and just brokers who are not willing to sit back on the status quo, but who want to take a more active role in driving those costs down, and not just, hey, we're just gonna, lump it up with the big three, or whatever. Like, I think my hope is that more brokers are continuing to challenge that status quo and find ways to really take more control and an active approach towards PBM. Because, I mean, like we said earlier, 20 to 40% of your spend maybe, I mean, we've seen significant savings for groups running through a transparent PBM model, and not just saying, not just mashing the easy button and saying,
Right.
go ahead.
100%. So, I mean, I think that the beginning is working with the outside of the box, and you've done that. And then the next question is what can you do next?
Yeah. All right. So you have a podcast. Tell everybody about your
Yeah,
podcast,
so I
about
do
what
have a
you do
podcast,
here.
and I will definitely get you on there as well. So I started a podcast this year called Influencers, and mine is more designed for the average American to understand that there are people making splashes in our space that are influencing where this industry is going. And that,
Mhm.
really is who I try to focus on there. I've had some really cool guests. I had a woman out of California who, not in our industry at all. She actually worked at Netflix as an engineer, and she had some trouble with her own, medical claims, and she created an AI free website that basically members can go to fight their claims based on diagnostic code. So like you put in what your denial code was, and it auto generates letters to the carriers for you. And now she just left Netflix to go like really build this thing. I think it's called is it makeyourinsurancecarriercry.com? I'll find the link so you can get in the comments, but it's like She's amazing and she is going to do a lot. And that's like the kind of people I'm trying to put on and give a platform to.
Yeah.
And help, you said you told your friends before this episode. That's who my show is for. It's for people who don't know what a PBM is and why they should,
Yeah.
and people who don't know, how to use their benefits. Last night at dinner, I had somebody ask me about what they do if they go out of the country with their own insurance, and they didn't realize that like pretty much every policy has some form of urgent, emergent care in there, no matter where you are in the world. And so, just like little things people don't understand, and trying to offer help.
Yeah, no, that's incredible. And I think that's a wonderful spot to be, because I remember going last year for I think my annual visit to my primary care doctor, and I was dealing with just these massive migraines, and I think it was actually a side effect of another medication that I was taking at the time. But the doctor was like, "Well, here, let me just give you some Nurtec now. It's a specialty, and if you want to keep taking this, then you'll have to." And I was
Yeah.
like, I know how this works, and part of me was like a little frustrated that like that was the first one. But I think like what you're doing is, because I think the average person is just like, yeah, sure, okay, but they don't realize maybe what the potential impact is on an overall plan, or hey, that maybe there's a generic, like what's the difference between a generic and a specialty, and all those things, like the things that you and I take for granted probably
Right.
because we read this stuff all the time. So, I mean, I love that you're doing that for the average person, to just break things down, cookies bottom shelf. This is what you need to know, and this is how you do it. That's so powerful.
Exactly.
Well, hey, I thank you so much for your
CJ,
time
thank
this
you for
morning.
having me. This was awesome. Great way
No,
to start the Friday.
this was so much fun. I appreciate it. Let people know where they can find you, if they need to find you, if they need to get in touch with you. Where are they going?
Sure. So you can find me on LinkedIn, Rachel Strauss. You can hit my website, rachelmstrauss.com. And very soon, pbmprincessllc.com.
Love it. Well, thank you so much. I hope you have a great weekend. You're the best, and we'll talk again. We'll talk to you again soon.
Thank you so much.
All right, have a good one. Bye.
Bye.